Thank you very much for the invitation and letting me come and share some of my research with you. I'm kind of excited to be here. One, it's sunny, and I'm excited to see the sun and be away from the snow in Boston, but it could be a little warmer, so maybe next time it'll be a little warmer. So I tend to talk quietly, so if you can't hear me, just let me know. So as my title implies, I'm going to talk about the use of MRI for breast cancer screening in the United States. And this research really came out of my career development grant. The piece that I'm going to talk to you today is data analysis. I like to kind of call it my modeler's foray into actual real data. I'm a modeler by training, and so this is really my first time at getting my hands on person-level data and actually using it, and the goal is to use it to understand trends to then inform the decision model in terms of what's really going on in the real world to make sort of more policy-relevant analyses with our decision model. So that's the background. I know you guys do both of those things, and so I certainly welcome any suggestions or advice you have. Please feel free to ask at any time. So just to get us all on the same page about, and here's some background and motivation, breast MRI, it's been around for a while. It was first approved in the US for diagnostic imaging in the 1990s. And then by the early 2000s, they had dedicated breast MRI machines that allowed you to image both breasts at the same time. So that kind of changed the dynamic of how it was being done. And like MRI, it's very high contrast images that are cross-sectional, and it means it's really great for detecting lesions. Interestingly, and I guess I didn't realize this when I started, that evidence to the effectiveness of breast MRI and how best to use breast MRI is really still accumulating. They don't kind of actually surprisingly know these things. What they do know is that it's better at detecting abnormalities than other breast imaging techniques like mammography. But because it's better at detecting abnormalities, it comes with a trade-off for higher risk of a false positive. In addition, at least in the United States, it's very costly. It's 5 to 10 times as costly as routine screening mammography. So how is it, or can it be used in the world of breast cancer? There's 4 sort of primary breast cancer-related indications or uses. One is in screening, so looking in healthy women to see if there's any disease that you could maybe detect earlier, and that's what we're going to focus on. But also it could be used for diagnostic workup, so if you have a mammogram that finds something, you can use this as part of the workup to rule in or rule out breast cancer. Breast MRI is also used once breast cancer is detected to look at the extent of the disease in the breast to help with staging, and then also sort of more recently looking at the tumor response to neoadjuvant chemotherapy. And then finally, there's surveillance. So when a woman who has a personal history of breast cancer, you can use it kind of like screening, where you're looking for recurrence, but she's otherwise sort of healthy. And people use screening and surveillance interchangeably, and you'll see that there's similar patterns as we go through. So again, I'm going to drill down and focus on screening, the use for screening, because that's my primary topic for this research. So what's the evidence for using breast MRI in breast cancer screening? So controlled trials and controlled studies show that breast MRI is very effective at detecting breast cancer in women at very high risk of breast cancer. So in fact, when it's used in conjunction with mammography, sensitivity can be up to 100% in some studies. But this is really only in women at very high risk of breast cancer. And so here we're talking about BRCA1 or 2 mutation carriers, which have a 50 to 80% lifetime risk for breast cancer, or women who have a very strong family history for breast cancer. Interestingly, the benefits in terms of whether or not it reduces breast cancer mortality, so its long-term effectiveness, are not yet known, and in part the studies haven't sort of been followed long enough to see whether that is borne out. People infer it could be effective based on the effectiveness of mammography. Again, even in screening, the trade-off is this higher false positive rate. And as you get down into lower risk women, it really hasn't been studied. The effectiveness has not been studied. So it's been studied for some women who are elevated but not super high risk. And you can imagine as you get sort of a lower and lower risk level that the trade-off between the false positive rate and the sensitivity may not always work out to a net benefit. But for women at higher risk, it may be that that trade-off between the higher false positive rate is kind of worth it. So it's never really been studied in women at average risk. I find also kind of interesting. So in 2007, the American Cancer Society came out with some recommendations for how best to use MRI for cancer screening. And they recommended that MRI can be used as an adjunct screening tool, so in conjunction with mammography, not sort of as in place of mammography, but in conjunction with mammography for routine screening for a select group of women who are at very high risk of breast cancer based on a family history. And they define that as a lifetime risk of 20 to 25%. That includes known BRCA positive women, and then there's a few other subgroups of women. So the American Cancer Society didn't make a recommendation on women with a prior history of breast disease or those with benign breast disease. So you can, from my definition, I would have called this sort of surveillance. So they didn't recommend have a recommendation about how to use it or using it for surveillance. And then they recommended against using it for women who have a less than 15% lifetime risk of breast cancer. And to place that into context, in the U.S., women have about a 12-ish% lifetime risk on average for breast cancer. So what really is happening in the U.S. with breast MRI? We actually don't know. We don't know how it's being used in sort of the real world. We know the technology's been available for a decade, but it's really only been studied in controlled trials or controlled settings. And we know that use and performance is usually different in the real world than it is in sort of controlled studies. There's really few studies on who's actually getting MRI, why are they getting it, and what happens when you get a breast MRI for screening. And so that's the motivation behind my career development grant. And the goal is we want to make sure that the right women are getting the test for the right reasons. So these are the three aims of my career development grant. The first that and I'll talk about this, is going to be just looking at who is getting breast MRI. What are the time trends in the use of breast MRI in a community setting? So we have no idea if women are actually getting breast MRI for any of these indications or at what rate. And second, if they're getting MRI, what happens after you have a screening MRI? Do they get a biopsy? What's the biopsy rate? What's the performance rate? What's the cancer detection rate? And so forth. So we think it's probably going to perform differently in the real world, but we don't know. And then finally, aim 3 is to take the sort of results from these and feed them into our decision model to understand, well, given actual use and actual performance, what are we getting in terms of population health and value for that use of breast MRI, and how best can we improve use? I'm making the hypothesis that we're not using it quite well. So. Okay, so I'm going to talk about the methods for aim 1 first. And for this, I have two main data sources. The first is claims data from Harvard Pilgrim Healthcare, which is a large not-for-profit insurance company in New England, and it has over 1 million covered lives. And here I have medical claims data and enrollment data, and a little bit of other data. The second is some electronic medical record data that we have access to. It's from physician medical practice that has multi-sites in Massachusetts, and it serves over 600,000 patients. This group was pioneers in electronic medical records, and they have electronic encounter data and free text provider notes about each visit that I could get access It has a small overlapping population with our Harvard Pilgrim population, so some people who are insured at Harvard Pilgrim can get care at HHS Health. So those are the two data sources. And I'll just describe, I had a sort of a little evolution in how I was going to do this analysis. And so I thought I would share with you my learning process in case as what not to do and how to avoid that from the very beginning. So I wanted to study trends in time, so I needed rate. And so my first attempt, and this is actually what I wrote in the grant, is that I was going to use the encounter data, get some abstracted information from the medical record data to get the trends in time. And I thought that would be great. You would have very rich clinical data. You could have information about breast cancer risk status. You could have information about the indication, and wow, that would be done. But unfortunately, that's not true, as I discovered. That medical record data from this site was really encounter data. So I had orders for breast MRIs, but I didn't know if the woman actually got the MRI and when. So there were times when a woman may have 5 orders for a breast MRI and never got the MRI or got it at a completely uncorrelated time. So you had no way of knowing. So I scrapped just using those data, and then I decided I'm just going to use medical claims data, a bigger population, so I could have a bigger population to study, and that would give me a better time trend. That has a pitfall that claims data is really not specific to the type or use for the MRI. It can't tell me whether there's a screening MRI or a diagnostic MRI. There's just one billing code for breast MRI. So my third attempt was to use a combination, and you guys may have said, why didn't she know that from the beginning, but this was my first foray into actual data. So what I'm going to do is I'm going to use my subset of overlapping patients to essentially predict indication. So we're going to develop a prediction model. I have women who have both claims data and electronic medical record data. From the electronic medical record data, we abstracted the sort of true indication for the breast MRI. That was going to be our gold standard. And then in the claims data, we developed sort of predictor variables, things like the occurrence of different procedures and the timing of those procedures and diagnoses relative to the date of the breast MRI. And we're going to use that to predict what the indication is. We used multinomial logistic regression because we had 4 different indications, and it was useful in this situation because our data was unranked categorical data. So once we had our model, this is very simple. We just apply our prediction model to our claims data. We've got the rates, we know the denominators, we have population-based rates. We used join point to analyze trends over time. I don't know if you're familiar with it, but it's a nice piece of free software developed by the National Cancer Institute. And they developed it originally to study trends in cancer incidence and mortality, and they use that for reporting their SEER cancer statistics. And essentially just find statistically significant changes in trends, and you can have a linear model or an exponential model. And it's free. Okay, so here's my study population that I ended up with. It's women 20 and older from 2000 to 2011. And from Harvard Pilgrim, we had 10,000 women who had at least one breast MRI during that period. And altogether, they had about 18,000 MRIs between themselves. So we have a subset of about 1,000 women who are in both data sets. We have claims and electronic medical records, and that's what we're going to use to build our prediction model. So here's our prediction model accuracy, and there's sort of a lot of numbers, but I think the main thing is our overall accuracy was about 82%. It's not, it's not perfect model. One of the things that it does do is it kind of misclassifies surveillance and screening as diagnostic and vice versa. So, and they almost balance out. And so for this analysis, we're interested in trends. We're not interested in what the indication is for any specific MRI MRI. So if we misclassified one from one bucket to another, we felt that's an okay trade-off. So this was our final sort of prediction model. Okay, so now we turn to some results. This is the overall time trend of breast MRI use. It goes from 2000 to 2011. This is regardless of indication. Rates go from 0 on up to, it peaks at around 130 per 10,000 women. And so you can see there's a rapid rise in breast MRI use over this time period. And in fact, using joint line, it's a 46% on average annually increase during that time period, which is pretty steep. And then in 2009, it begins to sort of level off or decline. So that's overall. We can drill down and look by age and calendar year. So here, each cluster of bars is a 10-year age group, and each bar within the cluster is the calendar year. So you can see that across the age groups, the sort of trend, the sharp increase is sort of the same across different age groups. The time trend is the same across age groups. The majority of the use is in the 40s and 50s, which is kind of what we would hope for breast MRI for any of the indications, I think. And we would hope that older women probably aren't getting it as much, and that's what we see. So here, applying our prediction model, these are the trends by indication. Again, the same time frame on the slide. So you can see that diagnostic, well, all indications are increasing over time. Diagnostic use was really the highest, or used the most. It was used the most for diagnostic purposes, sort of prior to 2009. And then in 2009, there was a pretty steep decline in use for diagnostic. Screening and surveillance, you can see, kind of mirror each other. And together, they account for about 60% of all breast MRIs in 2011. So they kind of overtake the diagnostic use. So interesting, people have asked, why 2009 is there this leveling off and a decline? And it's not totally clear. There's probably a couple reasons. One, in the U.S., they had a Deficit Reduction Act that kind of kicked in at this point, which tamped down on reimbursement rates. And so if you look across all sorts of procedures and all sorts of medical care, there's a dip. And so it may just be mirroring trends in everything else in reimbursement and utilization that's being tightened down. In terms of diagnostic use, which kind of seems to show a bigger decline, so the recommendations are where diagnostic is supposed to be used for diagnostic workup. They're actually a very specific, narrow subset of diagnostic workup. It's used to rule out biopsies. And there was a suggestion that it's being overused. It's being used in cases where it's probably not going to be helpful. You were already going to do a biopsy. Why did you need to do the MRI to confirm that? And so there's a kind of a push among the radiology community and other clinicians to kind of tamp down on some of the overuse for diagnostic purposes. So that could explain why diagnostic purposes take the dip. So did the American Cancer Society guidelines have any effect? They came out in 2007, which is where that dashed line is. And you could probably say, well, probably not. So here I graphed the purple line is screening and surveillance combined. And you can kind of see more clearly that it was increasing before and it's increasing after, and there's kind of really no change. So this really, I don't think the guidelines themselves had any effect on the trends. We were kind of expecting to see maybe a spike or a huge jump in increase when the guidelines came out. And it's more likely this is just reflective that the evidence base had been accumulating. Yeah.
Quick question. For the guidelines to be implemented in a practice, there is always a period that it takes.
That is true too.
Usually, I know for resuscitation guidelines, it takes between 1 year to 2 years. So
it could be that we're just seeing it, and it hit right during the 2009 period where they're tamping down. That could be. I do think that this also just the evidence base there were other guides. There are a few other organizations that have guidelines out there, but more and more are coming. But I think that's a good point, that there is going to be a lag.
This is really cool work. Can you talk a little bit, I might have missed this, about sort of where reimbursement policy is? So obviously, if you're over 65, you're in Medicare, but if you're under, you're not. And we're all insured, I might have missed that. Are they all covering this?
I don't know about all insurers, so these data are from Harvard Pilgrim Healthcare. They were covering it for specific indications. So if you met their criteria in terms of the RCA positive, have a family history, and the radiologist recommended it, and things like that. So it's a little bit loose, but that is another sort of element to the time trends that we're seeing. So reimbursement rates in the U.S. definitely.
The policy didn't change in this period.
Not according to Harvard Pilgrim administration. But maybe in other insurers, but I think there's, and I actually don't think Medicare covers it for screening. By the time you get 65, if you're BRCA positive, you've usually either been diagnosed or have done some other sort of preventive procedures. Okay, so now we know that breast MRI use for screening is increasing. How are we doing? Are we getting the right women into this particular program? So our study found that 1.2% of the Harvard Pilgrim population were participating in screening MRI. It was about 3,000 women. But studies have shown that up to 6%, maybe even more, may meet the ACS guidelines in terms of lifetime risk of 20 to 25%. So we're probably we're not getting all the women that we should. And even of this 1.2% of women, we may not be these may not be the right women who are getting it. So very few of them had an actual documented BRCA mutation. We know in claims that that's probably underreported anyway, so the actual number is probably a little bit bigger than this, but it's very few. Most of the women actually had a claimed documented family history of breast cancer, but like, well, this is probably overcoded in terms of an indication for breast cancer risk. It's not going to be very specific. To meet the ACS criteria, you need to basically have one or two or more first-degree relatives who have breast cancer who are premenopausal breast cancer. And this particular code isn't really going to distinguish between someone who has one aunt who has breast cancer and someone who has 10 family relatives who have breast cancer. So, but at least we know that of those who are getting MRIs, there's some hint that family history was important. So, we then went back to where we could to review the medical record data to say, if we could compute their risk score, how many would actually meet the criteria of those undergoing screening? And it was about 20% of those undergoing screening sort of met the ACS criteria in the U.S. We have a ways to go. So how's Ontario doing? So I put this in. You guys have a high-risk screening program. You're probably familiar with it. It started in 2011, and they just published the first year's sort of results. So your program offers annual mammography and MRI for women 30 to 69 who meet basically the ACS criteria. They are a little bit stricter in that they say 25% lifetime risk. The ACS sort of leaves it a little vague, but it's also BRCA positive women. At least in the paper, they estimated less than 1% of the Canadian population would be eligible. If I did my computation right back of the envelope from your population statistics, I thought it was maybe 20,000 women, but I'm not totally sure. So thinking about the uptake that they did have, it's about 2,000 women, and this is just in the first year. But all of the women who participated obviously met the criteria. These were truly high-risk women. 37% were actually BRCA positive. Basically, the rest have this very high lifetime risk. So that's very different than the U.S. population. So they say, well, okay, maybe a little bit lower, 2,000 women. It was the first year, so I'm sure it's going to go up. But you guys have much more rigorous criteria for who you're screening, so you're targeting the right women compared to the U.S., which is haphazard. Okay, so to step back and summarize the trends, so this really was surprisingly the first study to look at these time trends, these rates over time by indication of breast MRI. And we saw that there was this rapid increase from very little use in 2000 on up through 2009, it was increasing. And actually, the use of breast MRI was increasing sort of faster than the use of MRI for other body parts. So other body parts saw 10 to 20% increases during this time period. Breast MRI, we're seeing 40 to 50% increases. So definitely it's picking up steam. We saw that use for surveillance mirrors that of screening. It sort of follows the same trend. It has the same rate. And again, there's little evidence for the effectiveness in surveillance settings. We think that screening, at least in the U.S., is likely underutilized still by those who would benefit the most, but at least our data is showing that there's also some evidence for some scope creep. So we're using it on women who are at lower risk than recommended. Okay, so on to AIM2. We now know that it's being used and we know at what rate, and we kind of have some sense of who's getting it based on their risk level. So now, just to say, and this is a work in progress, to say what happens when these sort of women at varying risk levels participate in screening MRIs. Are we doing more biopsies? Are they having more false positives? Again, they have a different risk characteristic than what's been seen in controlled trials, which really only studies of very high-risk women. So here, we're going to use our Harvard Pilgrim population, our claims data, and we're going to focus only on the screening MRI, so that small subset, not all breast MRIs this time. We're going to look at what happens after a woman has one of these. And we're going to attempt to use claims data to compute or estimate sort of test characteristics of performance. So here the goal of our analysis is a little bit different than our trend analysis. Here we really care about each individual MRI, and it was very important that when we had a screening MRI or could identify a screening MRI, that it really was a screening MRI, so that sort of swap between the two different indications wouldn't work here. So they have different rates of follow-up. So we wanted a highly specific way of identifying screening breast MRIs, and we're willing to sacrifice sensitivity. So we're willing to have smaller samples as long as we're sure that the ones in our sample are truly screening MRIs. So we worked from our definition to redefine our algorithm for just identifying screening MRIs. So we said in the claims data, basically you can't have prior breast cancer, that sort of makes sense. You can't have any kind of diagnostic imaging or procedure or anything in the period right before your MRI. You can't have had a prior breast MRI within a short interval follow-up, and so forth. So we think we did pretty good here. We got a specificity of 97%. It's much better than our other algorithm. And we were happy with that. Again, we're sacrificing sample size, as you'll see. But this was not estimated with multinomial logistic regression. This is just a straight. I learned my lesson on the multinomial regression too. Okay. So here's our new study population. We've actually added another year of data. We have a sample in Harvard Pilgrim now, so up to 11,000 women who've had at least one breast MRI. But when we apply our algorithm, we get about 2,000 who we think have had a screening MRI. And before we had about 3,000 using our other method. So we're more comfortable that these are truly screening MRIs. And together, these women had about 3,000 exams. If we look at BRCA positive, sort of beginning to think about breast cancer risk, It's about 7% that were BRCA positive in this sample. So again, it's probably undercoded in the claims, but at least we're increasing there. And the majority had a family history as documented in the claims. So obviously, to get an MRI result, it would be great to have radiology reports, which we didn't have linked to these data. So we're going to have to infer what the result of the MRI was based on the claims. So some work has been done in mammography doing this kind of thing, and they found essentially we just copied their definition, which was any evidence of a diagnostic procedure or imaging technique within 90 days following the MRI. We're going to call that a positive MRI. We did vary that cut point from 15 days on up to a year, and I'll show you how it changes sensitivity and specificity. We also had to classify whether or not it was a true positive, false positive, so we're calling any diagnosis in the 12 months following an MRI as sort of attributable to or false to that MRI. And here we're counting both in situ and invasive cases. So of our 3,000 screening MRIs, we looked at what percentage of them resulted in different imaging at 3 months, and then by either time you got out to a year. So 21% had any imaging or diagnostic procedure. That includes screening mammography at that time, because remember, it's recommended to be used in conjunction with mammography. If you drill down, 14% have had any diagnostic imaging or procedure within 3 months or 90 days of that breast MRI. So that's what we're calling sort of positive here. By comparison, looking at the performance of routine mammography in the United States, so we have worse specificity than Canada does. Our specificity is around 9 to 10% for mammography. So here, this is obviously higher at 14%. I was actually surprised it was that low. By the time you get out to 1 year, it's up to 30%. But most of the women, if they are going to have a diagnostic procedure, have at least 2 or imaging, though usually, and the most common were diagnostic mammograms and ultrasounds. So they didn't just have 1 image, they had 2 additional images. So the comparable statistic that was reported by the Ontario High Risk program is about 15% recall, but I think these numbers may be not comparable in the sense of 15% may be really okay if your population is super high risk and you're detecting more cancers. If it's lower risk and the majority is either false positives, then it may not be as good. Let's see. And then the final point that I wanted to just sort of say about this was our cancer rate, so whether or not it followed a true or false positive, or true or negative, true positive or negative MRI was about 1.8% in the year. So at 12 months, that was our cancer detection rate. And we think that that's probably an indication that we're definitely getting a higher risk pool. On average, when you compare it to what you see with mammography in the United States, the cancer detection rate after 1 year is like 0.5% as reported. So definitely evidence that whoever is participating is at a higher risk than average. So here is our attempt at an ROC curve. So I had mentioned that I used a 90-day cutoff for defining a positive test, and you can slide that cutoff anywhere from 15 days to a year, and you can have a sensitivity and specificity estimate. So for 180 days, I just picked one. We estimate that the sensitivity of screening breast MRI is 65%, and the specificity is 81%. It's actually, so this is, there were 3 published studies that I could find that had similar estimates based on our definition of positivity, and so obviously they have better performance. So these are among high-risk women, and again, we have a different risk pool here. So I actually didn't think we were that bad. I expected way worse. If you look at positive predictive value, we get about 5% for our positive predictive value. Routine mammography in the United States is about 4%, so it's maybe a little bit better than mammography. Your high-risk program had a positive predictive value of about 7%, and then some published studies, there's kind of quite a range. So I think I was, again, sort of pleasantly surprised, but maybe when you compare it to mammography, it's not that much better. So stepping back, what are some implications from what we found? So in general, the use of screening breast MRI is increasing rather rapidly in the United States. And the women who are participating receive a lot of imaging. 14% of the MRIs were followed by workup within 90 days. That affected 20% of the women, because women can have multiple MRIs if you do them annually. So that can add up, especially if you go to lower risk pools and begin to use this in different types of women. So when you look at mammography in the United States, where again we have worse specificity than Canada, after 10 annual mammograms, the risk of a false positive, at least one, is up to 50%. So a specificity of 10% versus 14%, and if you're going to continue to repeat this annually, this could really stack up for women as you get worse specificity, especially if they're lower risk. We can say that at least our higher cancer rates that we're seeing make us think that we're getting at least some of the right women, but again, we don't think we're reaching all. And I think the other thing to keep in mind is the long-term effectiveness of breast MRI at reducing mortality is really not known. So it could be the cancers that we're detecting by MRI, especially maybe in the lower risk women, are ones that may not have harmed the woman or would have been detected later by mammography. There may not be that big of a benefit from adding MRI. Despite all the unknown benefits in the United States, there's a legislative push for women to be notified of their breast density and to have the suggestion that they would benefit from supplemental screening. So a screening test other than mammography. And women who have dense breasts, mammography doesn't perform as well, and you're at a little bit higher risk. So in the United States, different states are passing this legislation saying, hey, you have dense, you're told if you have dense breasts, you may benefit from supplemental screening. Go talk to your doctor. Some states actually mandate that insurance cover supplemental screening, particularly ultrasound, which has a terrible test characteristics. So we're a little bit worried. MRI is sort of in the same boat as ultrasound in that it's kind of neutral to breast density. So there's a thought that women who have dense breasts may actually benefit from MRI and have a better cancer detection. So both of these are kind of pushed, although ultrasound is a big but I think this worries us in terms of how it's going to be used in the future. Not only, so 18 or 19 states or more have this legislation that you're to be notified, and it's pending at our federal level as well. And the way that it works is if you have dense breasts, which is about half of women by their classification, would be notified. Okay, so what are our next steps? We've got the trends in use. We can figure out kind of by risk level who's using it and how much. We can figure out like what happens afterward, what's the downstream effect in terms of performance. The idea then is to feed those numbers into the simulation model rather than using sort of published estimates from controlled studies to find out what are the long-term benefits of using this in actual practice or in the real world. We can then design simulation experiments to say, well, what if we change this? How much could we improve population health? So thinking about the value. So that's our final step. And all that I'm going to say is thank you, and this is my mentoring committee.
in entry, I assume that you would get it from publication, but wouldn't it be more appropriate maybe to go into the data and get like a month control maybe?
Yeah, I think that's a good point, and I think if I had to do the grant over, I would have not gotten, so here I selected only women who had at least one breast MRI, and I think it would have been wiser to get women who didn't have a breast MRI but had similar characteristics. So I kind of wish I got it. The data were prohibitively expensive to get more. But to do the third aim, we're going to be working with the Breast Cancer Surveillance Consortium, which in the United States is a registry, is a consortium of screening mammography registries. And so they have mammogram results, and they're beginning to collect MRI on millions of women. And we're going to work together to do the same, so we would have a little bit more information about performance. Like, I think we can get actual test characteristics from the Breast Cancer Surveillance Consortium. From our data, we can get the actual resource use following. So, yes, I think that's a fair point.
Thanks again, Natasha, for your talk. I have two questions. One's practical and one's impractical. I'm going to start with the impractical one. I really appreciate how you talked about the different strategies and how it's the third one that I feel often that the data are out to get me as well. I remember you talked about multinomial loading, and I remember one of the classes I fell asleep in, they talked about an IIA assumption that you have to make independent of the relevant alternatives. Did you test, and if you were going to test and the data were going to reject that hypothesis, did you have a backup plan for what you would use in case multinomial loading would work?
No, I did not test. I'll put that on my to-do list. Or maybe I don't want to test. But I did have a backup plan, and it's actually what we started with, which was something sort of akin to what we did for screening MRIs, which was just to sort of work from the definition and say if it was this. But the problem was hierarchy. So you could meet the same criteria and be in two different buckets, and it was difficult for us to distinguish which one had priority. But I think that there are different ways, whether or not it's like the classification trees or things like that that other people have done that we've certainly thought about. And we actually thought about doing a methods paper comparing different ways of distinguishing the indications and which one works the best and things like that. So if anyone has interest.
And now maybe the practical question. I think you were saying that the right women aren't getting this and the wrong women are getting this. Do you have a sense about why that might be happening? Is it too difficult to find the right women to get this and too easy to test the wrong women?
I think it is hard to find the right women in terms of getting them to risk assess, getting to be assessed for their risk and things like that. In the United States, we tend to use the Gale risk model to get a risk estimate, which is not based on family history. And so many clinicians, you can plug it in, it's on the NCI's homepage, so many clinicians might use that. It's quite easy to get to a 20% lifetime risk with the Gale model, but that's not the criteria that the American Cancer Society sort of recommends. They recommend it based on a family history, which is very different. So you can have a bunch of other risk factors that get you to 20%. So it could be that we're seeing a lot of women getting the Gale model. Hey, look, you're at 20%. Let's go. Women who have dense breasts. When I reviewed the medical records, which I read in excruciating detail, 1,000 of these. There's a lot of hints that, oh, you have dense breasts. You may benefit from having this MRI, so it could be those women, but also the healthy women effect who want this latest and greatest test.
Really nice talk. So how do you know that the American Cancer Society and the Gale model are right? I mean, is it maybe the case that everybody should be getting? It sounds like it has a higher sensitivity, but also a lower specificity. So you've got a high false positive rate, and it may be that
that's a good point, and I think that could be true. One, again, the cost is prohibitive to do a mass screening program in the sense that it's 5 to 10 times. And there are other sort of drawbacks, too, for doing it sort of in mass. One is that a woman would have to sit in a tube for 40 minutes to an hour to get the image. Some women are claustrophobic, and that produces anxiety, so you can think quality of life from just participating in screening may be much worse because of reaction to the contrast fluid and things like that. So there may be other barriers, and also you just don't have enough MRI machines to do it. There may be barriers like that. But some people have certainly called for use in screening. But again, we don't know the long-term effectiveness. And so using it in average-risk women, we may be picking up, say, in situ disease, which never was going to progress to invasive cancer. We kind of don't know what we're getting with MRI yet.
Are you planning to use your fantasy model to kind of think through some of those issues, or is this more like sort of retrospectively analyzing the easiest recommendations and making sure the right recovery moving forward to say how this might guide the evolution of guidelines?
I think so. It may. So I think there's. I don't think there's enough data out there to know like which cancers you're detecting with MRI, and I think that's what makes it so uncertain. And it's going to make it difficult to model the long-term effectiveness if we don't really know. So we can, it may be the distribution of cancers is very different than that of mammography. We know that, for example, ultrasound doesn't pick up PCIS and calcifications, whereas mammography does. And so there could be different things of what you're picking up. But I think that's a fair point, in that when we go to look downstream, we would have to consider. I think part of the problem is there, and I'm not as well versed in surveillance, but I don't think there's been any studies of women who have breast cancer. They kind of don't know what the best technique is for surveillance. Mammography may work in some situations, but if there's scarring and things like that, that it may not be the best. And so there's even sort of questions about routine screening using mammography still that is left unanswered. So I think that is kind of an area that's open. I know that there are a couple people studying that, partly through the Breast Cancer Surveillance Consortium.
So you mentioned before that the MRIs are scarce. So like having utilized an MRI machine is probably gonna have an opportunity for someone else not being able to use it. And I was wondering whether this is something that is also of interest in the decision. Like would you take this waiting time into account in your model, or?
I think that is a good point, that you could do that. I think that at the population level, I think we may or may not. I think that would be just an extra factor that would affect. So here we would just mainly consider what are the benefits and harms. I think you could add that on to think, well, how many MRIs would we actually be doing, and do we have enough resources for that? But yes, I think that could be a rate limiting. And I think a lot of women would not tolerate breast MRI as screening tools. So when I was reviewing medical records, there were numerous women who had prescriptions for anti-anxiety medicine to go get their MRI. So.
One very practical question about working with THETA in the U.S. How do people switch insurers? Like, do you have a way of keeping track of how long you've got women in your cohort?
So these women were on average enrolled, I think, for 5 or more years. The women in our cohort. This one, I think think Harvard program is fairly stable, but I think if you're in it, you're in it. But there is a lot of switching, and so we do lose women, and you do lose. So I'm not counting a bunch of MRIs because we didn't have enough eligibility
You
time.
just sense them at the time that they switch.
Yeah.
And so you know for sure when they're.
I know from enrollment data when they're in or when they're out. So there is a lot of churn in these, and it probably is going to get worse. Maybe. People say that.
Just a really quick one. So it may be that we can't show that guidelines cost use, but you might have shown that use cost guidelines. Did you, with your results, get any reactions that were unexpected? Did people agree with your findings?
I don't think anyone positively or negatively. At the same time, my study came out with the rates of use. Another study from the Breast Cancer Surveillance Consortium came out, essentially showing they can't get population rates, but they can get other measures of risk, and it basically showed the same trends. So we do think we're on the right track, but there wasn't a huge media.